Thank you, Peter, and thank you to Sharon as well for inviting me to speak at this meeting. This is something that we're very interested in, as Peter was saying. The left atrium's a chamber that I spend most of my working life poking at with some sort of tool or another. I'm talking about three-dimensional mapping, or what we call electroanatomical mapping, because we combine electrical information with anatomical information. But the story of this mapping really goes along with the story of our investigation of atrial fibrillation in general. And so the seminal point, I think, in our understanding of atrial fibrillation that led to a cure was the finding that, about 20 years ago, the finding that atrial fibrillation usually begins with an ectopic beat. And the ectopic beat almost always comes from the pulmonary veins. Not always, but almost always comes from the pulmonary veins. And so that important observation was published in the New England Journal. And then electrically, it looks like this. So I'm not going to show too many of these sort of electrical pictures, but just so you can get used to the idea, down the bottom here is a surface ECG. And there's an ectopic beat there, and then there's a sinus beat, and then we see an onset of atrial fibrillation. The next group of 5 electrograms there are from the coronary sinus, which, as you all know, is a structure between the atria and the ventricles. And so not surprising, if we look at the sinus beat, there are atrial signals and there are ventricular signals in that area. And then the one above is in the left superior pulmonary vein. So all these electrograms are in the left superior pulmonary vein. So sinus beat, and then we see the onset, and the onset is in the left superior pulmonary vein. So here, that's the earliest point that we see. So, and we see very rapid firing in here. So very rapid firing of electrical signals from the pulmonary vein, leading to this pattern that looks like atrial fibrillation down the bottom. Now, the first people to cure atrial fibrillation were actually surgeons rather than cardiologists. And that was actually 10 years before we had this understanding of how atrial fibrillation begins. And this time, the surgeon involved, whose name was Jim Cox, was trying to interrupt the big short circuits in the heart that were responsible for atrial fibrillation. And so he thought, well, I'll make all these big incisions and divide it all up so you can't have short circuits in the heart. But you can see he did this incision around the pulmonary veins. And he did that for surgical convenience because it was an incision that he was used to from doing heart transplants. But it worked out very well because probably that incision rather than anything else he did that made the procedure successful. And it was quite a successful procedure. About 20 years before that, there was an understanding of the anatomy of the left atrium such that the muscle of the left atrium extends into the ostia of the pulmonary veins. So we can see the pulmonary veins here and muscle sheaths going into the veins, which end at some point. So you can pick up electrical signals in the vein to a point, and then at some stage that electrical signal disappears. And so procedures were developed based on this new finding of the ectopic beats causing the atrial fibrillation to get rid of the triggers that gave rise to atrial fibrillation. And so there were electrical catheters developed that you could put into the heart through a sheath. They had nitinol cores that made them form a shape once they get in the heart. And so we have this circular mapping catheter and then this ablation catheter. So the circular mapping catheter records the signals. The ablation catheter allows us to heat up the heart. And what we do is we pass an electric current between the distal electrode here and a big dispersive electrode on the back. And there's a resistance in there, and the highest resistance is, or the current density is highest closest to the electrode. And it heats up like a light bulb, like an old-fashioned light bulb, an incandescent one. And we just heat it up between 50 and 100 degrees, and that's enough to form a scar in the heart. And so we can interrupt the fibres connecting the left atrial body to the pulmonary veins. And that's great. And that did work. And it looked like this, because we did it with an X-ray. So we did it all on X-ray, and we have our little circular mapping catheter, ablation catheter, and this is a coronary sinus catheter. So this is an RAO view with a decapolar catheter, so a 10-pole catheter sitting in the coronary sinus. And this is what the electrical signals look like. So again, surface ECG down the bottom showing sinus rhythm. Up here, we've got some potentials in the pulmonary veins recorded from one of those mapping catheters. And as we heat up the connection, so we look for the earliest spot, heat it up, and we get delay and then loss of those potentials, which is great. But there's a few problems with that. The first is that we found that when we heated in the vein, it would narrow the vein, and sometimes that could be a very serious problem. Also, we didn't get much of a definition of the anatomy from X-ray. We needed to have a better idea because there's a lot of anatomical variation. Everybody's heart's different, like everybody's face is different. So everyone's got their veins in different places. Some people have more veins, fewer veins, whatever. Difficult to remember the combined electrical and positional information. So it's not so bad when we're isolating veins, but when we're mapping a big short circuit in the heart and we're trying to remember where the catheter was and where that electrical signal was, very difficult. So we needed something to overcome that problem. And we used heaps of X-ray. It wasn't unusual to have an hour of fluoroscopy for these procedures. It didn't quite get to the point where we had to burn all our clothes and go in a decontamination chamber, but it was very close to that. And so we wanted to do this. We wanted to have something that showed us what the anatomy was. This is a CT rendering of the left atrium. And we wanted to be able to, put lesions in where these little red dots are, away from the veins, so we didn't narrow the veins. And later we found that the wider that isolation was, the more effective the procedure was anyway. So we really wanted to make it as wide as possible. And if possible, do this sort of thing, which is what we like to do, where we do just one single ring around all the veins, which is like that Cox-Maze procedure, the surgical procedure that I showed you earlier. So that's what we're aiming to do. And so these electroanatomical mapping systems were developed, and they have three components. So one component is a system for identifying the position of the catheter in the body. And the way that system works is you have this sort of gadget that you put behind the patient. It's got 3 magnets in it. The magnets have their own particular signal that can be identified by little coils in those plastic-coated wires or catheters that we put in the patient. So they've got 3 little orthogonal coils in them, and they can identify which magnet they're getting the signal from and how close they are to that magnetic signal. And because you've got 3 of them, you can triangulate the position. So it's like a GPS in the heart. And we can identify where that catheter is in 3-dimensional space. And then we've got a group of amplifiers for recording the electrical signals, and then we have a computer to put it all together, and we look at it all on a screen. So it's like a big video game. And all our procedures, we're just looking at that screen all the time like a video game and moving the catheters within the heart. And so we have this magnet thing to identify the catheters. We can also use current in the heart. And the impedance throughout the body is not even because all of the structures have a different impedance. But when we move a magnet catheter around within the heart and know where we are exactly, we can form an impedance map, and then we can use that impedance map to identify other catheters that may not have a magnet in them. And so I'll show you how that works. But it means that then any catheter we put up in the heart, once we've got that impedance map, we can identify where it is using the impedance distribution. And so this is an example of what we call a merge, where we move the catheters around the heart, make an impedance map, also get a geometry of the heart from that movement of the catheters. And then we don't have to do this, but it sort of makes it a bit easier sometimes. If we have a picture of the heart, which we get from a CT scan or an MRI. And so here's a CT rendered image of the left atrium. And there's one of my catheters, a little circular mapping catheter. There's our ablation catheter there. This is the coronary sinus catheter. Now it should be straight, right? Because it should be in the coronary sinus, which is a fairly straight structure. Now it should be sort of around here somewhere. But it's all curled up in a ball. And that's because it doesn't have a sensor. So the system doesn't really know where it is. It's just guessing based on impedance, and our impedance map hasn't been made. But then we start to move the lasso catheter, so the round catheter around in the heart. So it was in the left superior pulmonary vein. We're not using any X-ray. We're just moving this stuff around in the heart using this computer screen to guide where we are. I was in the left superior pulmonary vein. Now I'm coming down to the left inferior pulmonary vein. I know it's a vein because the signals, which are those pink ones on the left, they're disappearing when I go deep into a vein. So I'm going into the right, no signal, okay, because we're right up there. Then I come back and I'm picking up the sleeve as I come back. And so, I'm moving these catheter into where I think these veins are. And then Tegan, who's our technician, is moving the geometry, moving the CT around so that it matches my model. So we calibrate the system. And then she can turn it off. We can turn off the geometry that I'm making and then just use the CAT scan and move the catheters around within the CAT scan. And don't need any X-ray, just moving catheters within that CT scan. So you can see the right inferior pulmonary vein over here, the right superior pulmonary vein over here, left inferior and left superior here. And I could stop there, but I'm not, because I'm moving the catheter around. And the reason that I'm moving the catheter around is because I'm interested in these colours. And so the colours here are showing voltage. So they're showing the voltage that we're recording from the surface of the heart through these little electrodes. And I can use that to try and identify scar within the heart. So where it's purple, we've just made an arbitrary threshold here of 0.5 millivolts. And so where it's purple, we're saying that's fairly healthy tissue. But if we find that the voltage drops right down, we'll see that there's a low voltage area which will be a different colour. You can see, of course, when you go into the veins, you run out of muscle, and so there's a low voltage area there. But we're looking for areas of low voltage in the rest of the chamber. So I'm going to mess around here for a while getting a good map. But I didn't have to do that to fix the atrial fibrillation necessarily. If I just want to isolate the veins, I could have stopped and rested with the CT scan. Now, another interesting thing's happened. As I've moved this catheter around, this coronary sinus catheter has started to straighten out. And that's because as I move the magnet catheter around, it's measuring the impedance everywhere and making an impedance map within the heart. And then it uses that to localise this other catheter that doesn't have a magnet. So that's the principles of electroanatomical mapping. And there's a few variations to that amongst the different systems that we use. But that's basically what it is. The other interesting thing to notice is that as I move, the system here is recording the signals and it's identifying the activation time. And so what we're doing here is pacing from the coronary sinus. So you see a big pacing spike here, and then all our atrial signals are following that pacing spike. So the system is also recording the activation time in relation to that pacing spike on a beat-to-beat basis. And so it can then put together an activation map, so where the electrical signals go in the heart. Now, we don't care about that at the moment because we know it's starting at the coronary sinus, it's going elsewhere. But if there's an abnormal rhythm in the heart, and I'll show you that in a minute, we can record the direction of activation, find out what the mechanism is, and fix it. So because of this system where we have a lot of electrodes and we can record things very quickly, all these devices have been developed for recording stuff in the heart very quickly. There's this one here that has little tentacles. There's this one which is like a little umbrella thing that you put up in the heart, and it's got 64 electrodes. So if I wave this around, in the time that we were looking at that other map, I would easily have 3,000 points or something like that and have a very dense electrical map of what's going in the heart. These straight ones, we tend to use them in the pericardium, which we access via a puncture from the xiphisternum, or in VT, sometimes we'll use it in the ventricle. And there's this one here like a fly swat, which is a lot of fun. It's very soft and you can just flap it around in the heart and get electrical signals that way. And so this is an example then of going on and doing the ablation. So we're heating up the muscle here using the CT scan, heating up the muscle, and everywhere I'm heating it up, I'm leaving a little red dot. And so I'm going to make a little pattern around here showing where I've put the ablation. I'm not using the geometry now, just using the CT because we calibrated the CT position with the magnet system. And so here we go, doing more ablation like that. And then when I finish that ring, I can map the electrical activation within the ring there and find if there's any gaps. And there is a gap down here. And so this is like a rainbow where red's early and purple is late. And so the earliest point is here. I go back to this point, heat that up, and that blocks that signal there and isolates the back wall. There's different ways that we can show that. Here's one of these fly swatty things here. And then we might animate the activation like this and show little dots coming up, which looks very nice, but it probably doesn't help all that much. The colours are pretty useful by themselves. And then when things go well, it looks like this. So we'll have someone in atrial fibrillation, isolate the veins, and then this is from the coronary sinus here. This is the surface ECG. You can see they go back into sinus rhythm. But if you look at what's happening in the vein, it's still going along in atrial fibrillation. So we isolate the veins, the patient goes back into atrial fibrillation. Sometimes they'll come back on another, you'll see someone, they've had a procedure, and one of Dr. Thomas's patients turns up in your hospital and they've got some abnormal rhythm like atrial flutter. And sometimes they'll go away, and instead of that line healing with a thin scar, it'll heal too well in a couple of places. And muscle will reform back across the line. And if that happens, they can get all these interesting short circuits like this one, which is where the electrical signal breaks out of the ring and it starts up there and then it swings around and it comes in here and there's a gap here and it'll break in through there and then it's going to go around again and we're going to watch it coming around again. This is an atypical atrial flutter mechanism using the gaps in the ring to maintain the flutter, so it also breaks in here and then it breaks back out the top again. And so all I've got to do is take that patient back, fix up those gaps, and then they won't have any problems anymore, if we're lucky. So that's great. So we can isolate the veins and fix a lot of atrial fibrillation. But this is the big problem now. The big problem is, what do you do when the veins are isolated and they still have atrial fibrillation? And that's what we spend a lot of our time thinking about now. And so obviously, they don't have a trigger coming from the pulmonary veins. They've got a trigger coming from somewhere else. And so we can try and identify a trigger coming from another part of the heart, which is great and easy if there's a lot of triggering going on. So in this case, we have a triggering of the atrial fibrillation. Here we have termination, reinitiation. So when that's happening, we can use one of those multipolar catheters, move it around and wait for the initiation and get some information and gradually localize the darn thing. And then in this case, we found it eventually down here, got rid of it and got rid of the trigger so that it didn't reinitiate all the time. There might be short circuits. So this patient has isolated veins at the back of the heart. We're looking from the front. See, this is the torso here showing the direction that we're looking. And there's a short circuit up here. So again, rainbow, red, orange, yellow, green, blue, purple, back to red again. So it's a short circuit here. And if we look at the signals here, here's the cycle length of the tachycardia. So that's how long each beat is in the tachycardia and the atrium. And there's these very long signals. And if we follow it around, it covers the whole cycle length. So those signals cover that whole area there. So it's showing that the whole circuit is up here. And we can fix that sort of thing by putting a whole lot of, these are not red, they're white ablation spots, but the same thing, ablation spots across here. And that terminates the tachycardia here, you can see. And we make a line between the isolated area and the mitral annulus, which is over here, to block that electrical signal around there. So that's another mechanism of a continued arrhythmia after the veins are already isolated. Here's another one, last one I'm going to show you, which is just a focal thing coming from this area. This is a pretty dodgy looking geometry because I've used that tentacle-y thing to record the geometry. It's just breaking out here and it's spreading through the heart. It looks like a focal mechanism, but when I go here, you can see there's very small signals that precede the breakout just in this area over here, in that ridge. So the ridge between the left veins and the left atrial appendage, which is a very interesting electrophysiological way. There's lots of variations on these types of abnormal rhythms, which we call ligament of Marshall tachycardias. We can also use the electrical system, the electroanatomical mapping, to identify important structures in the heart. This one is the phrenic nerve, which runs down between the right-sided pulmonary veins and the SVC. And so it runs down here. And usually it's a fair way in, and so it doesn't get in our way. But this one's right where I would have wanted to ablate. So we pace there, find the phrenic nerve, mark its position, and then steer clear of that when we do our little heating thing there. A couple of other quick things to show you, just showing that we can use ultrasound. So we can use echo to make a geometry. And this is the case here where we use an intracardiac echo, which just has a very simple linear array, but it also has a magnetic positioning system in it, so we can identify where it is in the heart and its orientation. So we can work out exactly where that sector is in the heart that we're taking, and then we just move the sector around in an array like that, and then we pencil in where the left atrium is, and then the computer can draw the left atrium based on that information. And then we don't need a CT scan, we don't necessarily need to move the catheters around and make them merge. So this is another way that we can do it using echo technology. And the last thing I wanted to tell you about was just this other system, which is just really in its infancy, but it's a system where we basically use a type of ECG. So an extremely dense ECG that uses 252 electrodes. And then we do a CT scan of the heart and get one of those nice images like I showed you before. And then we can use what's called the inverse solution and go back and then project that electrical data back onto the heart and then try and work out what the abnormal rhythm is based on that information. And Inherently, there are some problems with that technique, so the accuracy is not that great. But I'm showing it to you just because this is probably something that will improve in the future and might be something that you see in your services. So just in summary, so the use of electroanatomical mapping or three-dimensional mapping has allowed us to do wider, safer isolation of the pulmonary veins. It allows us to characterise the mechanisms of recurrence after pulmonary vein isolation, particularly in that group of patients where they need more than just having the veins isolated. It allows us to map and treat complex arrhythmias, ventricular arrhythmias, for example, or arrhythmias in people who have complex congenital heart disease. We can identify important structures in the heart. We can tailor our ablation to the anatomy because everybody is different. And importantly, we can reduce the radiation to either no radiation or just a couple of minutes of fluoroscopy instead of using an hour of fluoroscopy as we once did. So thank you very much for that.